Welcome, everyone. And actually, I think this might be our largest ever, certainly I think it's our largest ever PPA support group. It may be actually the largest of our rare dementia support groups all in one place together. I mean, it's an amazing thing. And I do recognise quite a few old friends and also welcoming some new friends, which is very, very good to see. The first thing to say is that this meeting would not have been possible at all except for two people. Chris Hardy, who I think many of you know, who did an enormous amount of behind-the-scenes work to make it possible, and Emily Brotherhood, who I think most of you know, if you can get her to put up her hand, there she is, who really stepped into the breach at almost the last minute to sort of pull things together. So I'm very, very grateful to them for all the work they've done. I need to remind you about basic safety procedure. There are emergency exits fore and aft, and there's an assembly point on the UCL quad, which I hope you won't need, but if you follow the fleeing members of staff in the event of an emergency. Okay, so we talked about a couple of people there. We've got a number of visitors. So my usual fear in this situation is I will forget people, which is my problem. But a few people coming from a lot of different backgrounds actually to come and either lend their expertise or try and absorb your insights today, which is really fantastic. Some names that may not be familiar. So Asita Amasikira, who I might get, again, I can see him from here, put up his hand, there he is, who is a filmmaker, Punchy Films. There's a website for those of you that are interested. Is very interested in creating a film around the topic of dementia, people's experiences of dementia, and I'm sure he would really like to chat to as many of you as possible today about your experiences and to digest that. So it's extremely great that he is coming along today. We've got representatives, actually, the Alzheimer's Society are here as a delegation led by Angelique Myers, and I might get them to put their hands up. There they are. These are our very helpful team of monitors that, from the lay side of things, support our funding, and one of our major PPA funding initiatives is Alzheimer's Society funded, which is the MRI brain scan part of our study, and they are helping us with that, and also very helpfully coming along to try again and get some insights into a dementia that needs to be much more widely known about, which of course we all know about, which is PPA. So they'll be helping to take that back to the wider world. From one of our other major backers, Alzheimer's Research UK, we have Rachel Allen, who I might get again, there she is, who's a communications manager, Rachel, who is very keen again to get your insights and to see how best that can be represented, particularly back to her charity, but also to the public at large. So please do take the opportunity to chat to them while they're here today. One thing I wanted to say, because we have a number of things going on, and these comments of mine are also running on, but if people are feeling overwhelmed at any stage, or even if you just want to stretch your legs, we like to try and keep these meetings informal, so you should feel free to take some time out, move around, go to the other side of the room, etc. Just feel free to do that if you need to. That goes for sort of when people are speaking as well, just so you know that. Now there's a few notices just to let people know about. First thing to say is we're planning to record this meeting, and that will be on the website. And I think those of you that have been before are probably used to that, but just to make people aware of that. I mean, this is not obviously to breach personal confidentiality, but in terms of the general proceedings, we record them. And there's a couple of things we really wanted to highlight. One is Sept and Younghouse have really done a lot of work putting together this very, very nice new MOOC online course, Dementia in the Arts, which is flagged up there. And there are some leaflets, I think, strategically sprinkled around the room for people to have a look at that. I encourage you all to have a look at that. It's a great course, and Sept will be able to tell you some more about that if you get the chance. We have Carolyn Greaves, who is the coordinator of our PPA research study, among other things. Here, there's always a risk of asking people to put up their hands if people will not be present. But Carolyn, if you're here, this would be the time to identify yourself. Okay. She is very keen to hear from people who might be interested in participating in research. Many of you know that what that involves, but that is research based at the Dementia Research Centre, and she'll be able to give you some more information about that. We are, and some of you, again, we've discussed something like this with some of you, will be aware of this, very interested to start to do something which has not been done very well so far for PPA, which is to give particularly doctors and people involved in assessing people with PPA some signposts and guidelines about how to tell how far into the course of PPA they might be, which in medical jargon is staging PPA. And this is still, despite the fact that, you know, in the modern era we've been interested in PPA collectively for 2 or 3 decades, remarkably little understood. So someone comes to clinic, they get a diagnosis, well, how can we tell them, you know, where they're up to, where they're heading, that sort of thing. And so Chris Hardy's really spearheading this, but we're very, very keen to try to gather more information about that in the hope that we will be able to formalise that into something that looks like a set of guidelines, for staging guidelines for this disease. And that will go actually for other rare dementias as well, of course, not just for PPA. But they'll all have their own unique features. So what we need really is to canvass your views, if we can. So we'll be speaking to people about this in a more formal way to try and take it forward, but very interested to get your feedback. And actually, one of the other very exciting things about this meeting, which we'll talk to you some more about, is the commencement of these small discussion groups, which I hope will be a mechanism for trying to start to gather some of that information. But at the moment, it's really getting your impressions about what things are important and how things began and evolved, which are very, very useful for us. The other notice, just to give you, which it's a piece of paper I'm holding in my hand, is so Rose de Pestron, who again might kindly just put up her hand if she's, yeah, there she is, runs a young onset, North London young onset support group, Yo-Yo, which I'll let her explain the derivation of the terms. It's a very cunningly designed term, and people that are in North London in particular might be interested to chat to her some more. So this is one of the regional support groups for people with rare dementias. That's yeah. So PPA, but other rare dementias as well. Right. So just to run through the agenda. So you've been hearing from me, and I'll step down shortly. We introduce Anna Sobel, who we're delighted to have as an old friend here to give us our main talk today. And then what we plan to do is have a question and answer session, really capitalising on the fact that she's here. Hopefully lunch will be, if it's on time, will be around 12 o'clock. We are on a bit of a clock today in terms of the use of the room. Welcome, have been very generous in allocating the space to us. But we will need to be winding things up by about 2, and we want to allow plenty of time for our small support groups, our small discussion groups. Now, these are new, so we are very, very keen to give you the best experience of these as possible. Geraldine Bear, who again, Geraldine, if she's here, might put up her hand, there she is. Was a driving force behind getting this all up and running, and this has now been complemented by I think actually 8, or up to 8 small groups with intrepid facilitators who've agreed to lead those groups. We'll be putting up the details about the groups and the membership, and I'll come back to it before lunch to remind you what groups people have been allocated to. But just to say that we want to use this as a forum for you to be really frank and feel that you can speak openly. not to breach any confidentiality, but to really give your thoughts about the topics that we've identified, which is really understanding PPA, living with PPA, practical PPA, sort of trying to cover different aspects of the disease, and people have indicated particular interest for those groups. Feedback, ultimately what we want to do is gather that and pass it on to Chris, who's Hardy, who's acting as the coordinator. But we, I think 7 of the groups will have note takers, who are people really, particularly some of our young PhD students who are sort of working in PPA related areas, who've agreed to come and help just to be recorders, but not to inhibit you in any way. If people are not happy about having people sitting in, by all means do say, but they're really only there to help record impressions. But we'll come back to that close to the time. Right, so what I might do is, without too much further ado, hand over to our speaker. Now, so Dr Anna Sobel is consultant psychiatrist at Barnard and Haringey Trust, and she leads the memory service there. But she is a former refugee of the Dementia Research Centre and the Cognitive Clinic, and we would very much like to have kept her. She tunnelled out. Psychiatrists are quite cunning, actually. You've got to keep an eye on them all the time. So she escaped, but we've managed to reel her back today. I'm delighted for her to be here because she has a wealth of practical experience about the management of behavioural symptoms in PPA and other conditions. So, Anna, welcome.
Hello, everyone. Thank you. Such a warm welcome. It's so nice to see so many people here. Also, we don't get the privilege of the welcome building often, so I'm reeling in it at the moment. I'm going to try and speak quite slowly, but I'm a psychiatrist, so we use long sentences a lot. Can I have the business? Thank you. Good start. Okay, so I'm going to talk a little bit today about the kind of psychiatric presentations, so mood or behavioural things that we might see in PPA and in other dementias, but I'm focusing on PPA today. It's a field that obviously, a bit closer, sorry, it's just seemed very loud. A field that seems vital, obviously, in terms of being able to improve someone's adaptive ability in terms of the illness and quality of life. So, despite what some people may think, this is not what psychiatrists do. Can't help you with this, but I have no disclosures. So, I'm going to be talking a little bit about the type of presentations that we might see in PPA and the patterns of symptoms and the different subtypes of PPA that we recognise. I'm focused, because of the brevity of time, I'm particularly focused on the thing that we mainly see in PPA, particularly in the early stages, which is depression, looking a little bit about how we assess for depression, how people who have PPA can notice themselves whether or not they feel that there's a change in their mood, and whether or not carers as well can identify any changes. So how to assess really at home, how to escalate services if necessary, and the kind of treatment strategies we would use. And then questions at the end. So the reason that I put in this slide is just because I think it gives you a greater understanding of what we might see in PPA. So the NPI, the neuropsychiatric illness, first of all, to explain, neuropsychiatric illness is just generally any psychiatric illness. So it's any mood disorder, behavioural disorder that's the result of a brain disorder, which we think is all of psychiatry, but it has been bracketed as neuropsychiatry. And the research measures is what I very briefly wanted to talk about, because they're quite different to the clinical measures a lot of the time. So the research measures tend to be used something like this, which is the MPI. This is a shortened version. But these are the kind of things you're looking for when you're looking for psychiatric illness and PPA. And it gives you good breadth, so you get to see delusions, or you're looking at anxiety, you're looking at disinhibition, depression, but really it isn't very much detail in each one. In psychiatry, we would use the ICD-10, and under, for example, depression, we saw one question there, we would be looking at core features, how long it's been going on for, the kind of functional change, the change in what you can do every day, and what we might call psychological symptoms, which are hopelessness, worthlessness, feeling quite helpless. So it is a much more detailed way of looking at depression, anxiety, etc. Sorry about the bad jokes, it's a psychiatry thing. So the first thing we're going to look at is a paper that was by Fratelli, and I'm briefly going to go through the research, very briefly, because I think the important thing is to get through what we tend to see and how you can look for it. So essentially it was initially thought that PPA wasn't particularly associated with psychiatric symptoms early in the disease, but that's found to be not the case necessarily. And a study in 2011 by Fratelli showed that when you take a bunch of people that have PPA and a bunch of people in the population, actually there is an increased prevalence of these kinds of diseases of depression, irritability, anxiety, agitation, apathy and change in appetite. And it was markedly so statistically significant. This is just a very busy slide, just showing you that it is more significant. People in PPA have more depression, etc., irritability, and the variety of other symptoms that you saw on the last slide. Again, another study by Banks showed that people tend to cluster. This was a study that looked at behavioural variant frontotemporal dementia, so also as a result of FTD, but comparing BV FTD to PPA. And here you can see the PPAs are in green. Again, clustering mainly around mood and anxiety, which was what we would tend to see, but also nighttime behaviours, delusions, which is not that common, but you can see that there are significantly psychiatric symptoms in PPA. Yes? So it depends. There's a massive range of nighttime behaviours, such as difficulty getting to sleep, agitation before nighttime, waking up a few hours after you've fallen asleep, wandering at nighttime, becoming quite disinhibited or not knowing where you are, disorientated at night time, both in time and place, and that can continue on to the morning. And then you have early morning behaviours as well. So also waking up early in the morning, or waking up thinking that it's the middle of the day, so you day-night reversal, or not sleeping at all. So this slide shows also, and this is an interesting one because it was controversial, that actually as the disease progresses you start to show more psychiatric symptoms, so there are more symptoms. Looking at this was a study, the same study, but she divided them into people who had the illness for 5 years and then 5 years plus. And you can see that the short duration, that's what SHD is, didn't have as many symptoms, psychiatric symptoms, as the behavioural group here, but over the years, later on, they started to have more symptoms, more psychiatric symptoms. And also, what was shown is that there's a change in symptoms from more mood symptoms, anxiety, that become behavioural change and personality change over the years. So, this was from our esteemed friend, Prof. Warren, and his study essentially showed that the different subtypes of PPA, so semantic, dementia, logopenic, and agrammatic, can show the different language profiles show a different profile of psychiatric illness. The semantic dementias, you would see much more behavioural variant type symptoms, so change in personality, change in social awareness, whereas the PNFAs and LPAs are far more mood type symptoms, irritability, lability. Again, this was a review of the studies.
What does lability mean?
It means swinging in temperament. So, for example, one way that we might mark someone's lability, mood always changes, so it does fluctuate, and that's very normal. It's not normal if it doesn't fluctuate. But large fluctuations that can happen very quickly, we call lability, such as... So essentially, this study was a good review of the literature on psychiatric symptoms in PPA, and showed that actually the behavioural symptoms, the prevalence of behavioural symptoms was pretty much the same in all of the groups, but there were different type symptoms. The main ones, though, generally in the PPA group were the mood symptoms, apathy and, agitation, aggression, depression and apathy. From a psychiatric viewpoint, apathy is a difficult one because it's a behaviour, it's not a diagnosis. And actually, a lot of the time it can be quite difficult to tell why someone looks apathetic, why they're not engaging in the things they used to engage in. But we'll talk a bit more about that later. Again, another profile, this one is in semantic dementia, looking a bit more like behavioural variant frontotemporal dementia with the change in personality. The other one is agrammatic, again looking a bit more like depression and anxiety. And the last one, which I was looking at, was logopenic aphasia, which essentially, because a lot of people have got Alzheimer's dementia pathology, can look a lot to me like Alzheimer's dementia in clinic, in that you start to show anxiety, irritability. Later on you can have delusions and hallucinations. That's quite rare in PPA, but tends to happen can happen in this group. So I guess the question is really, how much does that help you? I'm not sure that it does help you very much, because from my perspective, what I'm trying to understand is how you could characterise depression and anxiety within PPA. So what does it look like when someone's depressed or when someone's anxious? And does it look different from the people that I might see as well who don't have PPA? And this is to help you try and recognise and understand what's going on. So there was a good study. This is again, just how we might diagnose PPA in practice. But this is a study where someone was using the geriatric depression scale, which is a measure of looking at mood, and it was very interesting in terms of the study findings. So one of the things one of the things that was good about it is it's a self-report, so patients themselves say whether or not they have a symptom. And the second thing is that you can group all of these questions into different factors. And the different factors are, because I always forget them, let me have a little look. They are anergia, so lack of energy, both mental and physical energy, positive, optimistic, agitation and restlessness, social withdrawal and feeling sad and pessimistic. And the questions are grouped into these themes. So what was shown actually was that a greater proportion of the PPA group had depression. What was also shown was that although a lot of them didn't have depression, they had higher scores on the GDS than controls, than people in the population. And also, interestingly, that as they didn't show increasing severity of depression with increasing illness, with how long they'd had the illness for. But particularly in terms of recognition of mood, what we would call the underlying things here on the left-hand side, low mood, anhedonia, which essentially means not being able to enjoy things that you previously used to enjoy, and anergia, lack of energy. These are the core symptoms for us of depression. So I would tend to see low mood and anhedonia as the primary two symptoms if someone is depressed. But with PPA, actually, what people endorsed was primarily a lack of mental and physical energy, and it goes in this line. So social withdrawal was the next thing, agitation, and then feeling sad and hopeless or lacking in positivity. And actually, that was the last symptom that people, in terms of percentages, that people are endorsing. For us, that is a very different pattern in terms of depression. And actually, it's been postulated that one of the reasons is because a lot of people who have PPA are still of working age, and therefore what they experience is lack of energy mostly. But social withdrawal is a very significant one, not going out, but you're not really sure why. But they do, you can superimpose them on some symptoms of depression. It's just that it might look a bit different. Sorry, go.
Could I just suggest that maybe social withdrawal to do with impaired language?
Yes, absolutely. And I think that absolutely bears out in practice, that it is to do with impaired language, and it can be very difficult to socialise when you're noticing that. And I think that's very true of all dementias, actually.
More comprehension.
Yeah, and absolutely an understanding. It's very much a feature, that's true, but social withdrawal is also a feature of depression. It's also a feature, it also looks like apathy, so it can be a difficult thing, but I absolutely agree. I think it's about the language. This is just another schematic showing the same thing. But what was interesting is actually the most endorsed statements were not about mood, and were not about social withdrawal, and were not about lack of energy. What they were about was cognition, a difficulty in not feeling sharp in your mind. And the other one, that you're noticing some insight into, I don't have the same memory as I used to have, and it's definitely not the same as other people's memory. So another thing that the paper found was that essentially you were going to have more chance of having depression in PPA if you've got a past history of depression, which makes sense, and along with our risk factors for past history of for getting depression are things like loss, bereavement, unemployment, change in circumstances, so you can understand the risk factor, and insight, being aware of the illness. And the last was actually the severity, how bad your language was, and that's exactly what you were saying.
So do you mean that insight is helpful or not helpful?
For what?
Depression.
So I think insight is a difficult one. I think that in terms of behavioural variant frontotemporal dementias, who are a correlate group to the semantic dementias, don't tend to show depression because it's thought of a change in insight because of a lack of insight. Whereas actually in semantic dementia, you can get depression quite predominantly. And that's, so I think insight isn't necessarily helpful in terms of if the cause of someone's depression is because of their reflections on what might happen and the illness and their functional change, then I think it's not necessarily that helpful to have as much insight.
So, for example, would you say that something like this presentation or this group itself is not helpful because it increases insight? Is that what you're talking about?
What I would also argue is having insight allows you to have the skills to try and maximise your function. So there's a bit of a balance in terms of... Okay.
Thanks very much.
No problem. So this is a patient of mine who I still see and still treat. She's not called Susan. She's a lovely lady who, sadly, as Jason was talking about, was one of those people that was diagnosed with PPA 6 years into the illness, which is really quite a long time, and really doesn't have very much language anymore, but is an excellent communicator, has brilliant non-verbal skills, and actually I can understand most of the things that she's trying to communicate, and so can the other people working with her. She actually came to me because she looked like she had what we call a psychotic illness. So she was delusional, she was paranoid, she thought her neighbours were out to get her, kept seeing her name on the television and thought it was a reference to her and something bad that she's done, so feeling quite persecuted. She was, when I met her, she was in her house, the curtains were closed, she wouldn't allow them to be open, she thought people were looking in, she kept saying that she couldn't go out, and kept phoning lots of distressed phone calls to her children. So what was interesting was that she actually had a urinary tract infection, and it's a significant thing because it's something you absolutely need to rule out when someone is showing an acute change in behaviour. So she had a urinary tract infection, we treated her, she was much better, and we gave her an antipsychotic, which is something we might do in a delirium where someone is paranoid about what's going on. And what was really interesting about her was that the emerging picture was actually a very depressive picture. So she wasn't going out, she was, the sentence there was about the fact that she felt that if she did go out and something went wrong, she couldn't say anything to anyone and couldn't troubleshoot her way out of it. Which is a really difficult thing. She was a really active lady, loved exercise, does go to dance classes now, loves football, lots of things that she liked to do outside her home. And she essentially became housebound as a result of her feelings. And what was particularly marked in her, that she has a very close relationship with her husband, who also has a mental illness, unfortunately, but they were very close. And the thing that she was finding most hard to deal with was not about how other people communicated with her, but that her husband couldn't understand her. And that had been going on for progressively and insidiously over time. So she would also get, she was scoring her mood quite low, about 4 out of 10, and we would use a visual analog scale for that, and I'll explain what that is. And again, seemingly didn't have any of those symptoms, as in she would be quite labile, moved toward between 4 and 8 quite frequently in the day, but her sleep was fine, her appetite was fine, and her energy levels were fine. So what do? Essentially, we break down treatment into the kind of aims for her, and then the structures you might use to get those aims achieved. And it is, and I can't say this enough, particularly for a psychiatrist, The treatment is entirely specific to the individual. So there are standard things that we would do, but it is genuinely about wrapping around care to try and understand that person's needs and what their personality is like and was like before they were unwell, before they were diagnosed. So the one simple thing is resolve any infections and to treat her depression, but really to allow her to look forward to the kind of things that she wanted to do that could be done just with adjustment. Identifying future goals, for example. The mainstay, I think, that I have found, you could call it treatment or not, is education, explaining exactly what's going on to the family, to friends, how to be able to communicate with someone who's got PPA so that they can adapt to the diagnosis and the changes in them. Care coordination essentially is under a psychiatric structure where you will have someone who comes to your home and sees you very regularly to assess you, make sure that you're okay, and make sure there's no crisis about to occur, and mitigate risk. And this is usually a psychiatric nurse that will come to your home. It's a really good thing in PPA, particularly because you end up building a really good therapeutic relationship with someone who gets to see you over a period of time while language might be changing, so that they have a much more chance of being able to communicate well with you. There are social interventions we'll talk about, and then psychological interventions. There is no way, because language is changing, that doesn't in any way mean that psychological work can't happen. And that's something I have to say quite a lot, because I think people don't necessarily expect it. So psychological work is just talking therapy, not the use of medication. The use of, It depends.
Could you repeat the question? Sorry, I didn't hear it.
Yeah, sorry. The question was, essentially as I understand it, how does that happen if someone needs to be able to talk for psychological therapy? So the answer is that there are lots of different forms of psychological therapy. One, for example, is art therapy that doesn't require speech in the same way. CBT can often be used in terms of writing or using pictures to explain. So, for example, using a thought diary, you can use pictures for that. We might ask people to identify their mood. So the homework for CBT could be used. I'll talk very briefly about CBT. But there are ways around it. Often getting people's communication boards to use those in therapy, and to do couples therapy so that you've got someone giving collateral information about what that person might mean. So it depends. And it is about working creatively. And obviously speech and language therapy. So just the assessment. What we tend to do is ask people to fill in their own mood charts, mood scales. You can do it on an app now. I thought I had a picture of visual. Here we go. So this is a really, it was the only one I could find, but a very simplistic visual analog scale, where you're going from sad face to happy face. And we ask people to pick that out over time. One measure is not necessarily that significant, but if you're doing it over a number of weeks, which is when we might see you, actually you can get a real sense of what's going on for someone and how they're feeling over time, particularly if you can cross-reference it against what they're doing at the time. Also how you're feeling in terms of how active you feel, whether you're feeling like you don't want to go out, whether you're feeling agitated, whether you want to do things. There's the change in social contact, and not just mood, but also feeling in terms of whether or not are you feeling angry, feeling distressed, you're feeling sad, and you can use things like, they're not great, sorry, again, off Google, but you can use, we've got better pictures in clinic, to try and explain what emotion you're feeling at any one time, not just whether or not you're low. Then there are some biological symptoms we need to know about. How's your sleep? How's your appetite? How's your concentration? And again, it becomes difficult. These are complex concepts to explain, but over time we can start to build up a picture for feeling hopeless, feeling worthless. This is for the carers. We would expect someone else to be able to observe what's going on. So facial expressions are a really obvious one and can be very helpful. Whether someone's crying or not during the day, whether they're crying and then laughing the next moment, those things are all very significant. What they're doing, activity levels, whether or not they're still making choices, because that's actually an indication of engagement, an indication of what you might want. And if someone's not making choices anymore, we would worry about how they're feeling. and what they want to do in the future. If there is no engagement in future planning, again, we would want to know a little bit more about what's going on. And these are the records we would expect a carer to fill in. So this is what would happen in clinic. So if you were to see me, for example, we would get all of this information from the carer and from yourselves, from the person who's suffering from PPA. Try and understand a bit more about what you like to enjoy, what were you enjoying before you were diagnosed with PPA, so what we would call pre-morbid personality, and then use mood scales. There are some validated scales we might use, like the Cornell, the Hamilton, but in the initial stages, maybe not. So, sorry about the busyness of this slide. It's essentially to show that services are set up, don't always communicate brilliantly with each other, but they are set up to be able to allow you, someone else, to negotiate with you around this. That tends to be the care coordinator or the CPN. But there are loads of different structures that we can use: outpatients, day hospitals, day services, being seen at home, where you can be reviewed over time, and also lots of interventions that can occur. So things in the community, such as groups like this, but other groups, day programs that don't necessarily rely on language, respite care and carers befrienders. For example, the lady that I was talking about before, she wanted to go across London to see her sister, and it was a thing that really upset her that she couldn't do that anymore, because she was worried about getting things wrong, and then what would happen if she got things wrong and needed help. So she initially employed a carer, and we did it with the CPN as well, to go out with her, to take her across London to go and see her sister, which she enjoyed. So she built up her confidence to be able to go out there, and she's done it alone on her, and is actually very well now. So the point of services is to be able to see you as early as possible, so that we can build up a relationship with you to try and understand what your needs are and to optimise communication. The treatment is symptom specific, so if someone is feeling low, if someone is feeling anxious, if someone is feeling irritable, and care coordination and risk mitigation are going to be one of the main points of treatment. Again, there are home adaptations we can talk a bit about later, and to have an advocate, to think about your wishes in the future, and actual care support if needed. So, we were essentially talking about the kind of behavioural strategies we might use, that tailored behavioural strategies. So, if someone is feeling apathetic, that we might use goals to go out, the type of things that are going for a walk for 10 minutes, and then you would build that up. Activity scheduling, and also irritability, agitation responds quite well to exercise, and actually has in the patient that I was speaking about. So she does a dance class, lots of good days of the week, I can't remember, but is really active actually and enjoys it thoroughly. So we've also got her an information card, because she's worried about when she's out on her own needing to communicate. We've created a care plan and a crisis plan. So the psychosocial support that we were talking about, we could talk about it a bit more in terms of questions, the kind of centres that are day centres where people can go to learn new things. There was an iPad class last week that we had a cohort of people going to that they enjoyed, but a variety of different services that are set up. They're not great they're not particularly tailored to PPA, they're tailored to dementia, but depending on the kind of people that work there, and we've got good links with services, they can really help to build up relationships and make people feel welcome. And then I wanted to talk about medications last, because it's not necessarily the mainstay treatment, but it is something we would use. So the kind of medications and the evidence are antidepressants, mainly what we call SSRIs, and they're a particular group of antidepressants. They can help a lot with the lability, emotional dysregulation. They can help with, obviously, depression, and have been shown to show some difference in terms of eating changes. The one we would mainly use is sertraline, but trazodone, well, the first one there, is slightly sedating, and we can use that if people are agitated or they need help sleeping. The others are mood stabilisers, such as something called carbamazepine. We might use that quite frequently, very good for agitation, and also change in social awareness. And then lamotrigine, which is we predominantly would use in depression or lability. the antipsychotics, and they can be quite controversial, but the antipsychotics we might use can be very, very helpful, particularly obviously if people are experiencing hallucinations or delusions, and can, the one that we tend to use is risperidone, but we do use all other antipsychotics. There is lots and lots of evidence. And then what's interesting is that the two things that were mainly endorsed in the GDS on the previous study were the things about feeling cognitively not sharp, and that being the reason that I'm feeling low mood or I'm depressed. And you would think therefore maybe a target for treatment might be cognitive enhancement, which is a difficult thing, particularly in terms of when it comes to medications. They haven't been found to be particularly helpful, and only really if someone's got Alzheimer's dementia pathology would we use some of the Alzheimer's dementia drugs.
Excuse me?
Yeah.
Can I just tell you mentioned trazodone tablets, and
Yeah.
I just thought you'd like to know that I'm taking them for my memory issue.
Are you? What do you think?
Well, you probably know that major professor, female Giovanna Malucci, has decided that trazodone tablets might be able to cure memory. She did tell me that it would take at least 1.5 to 2 years for me to take them before it might, and hopefully will do something. And I've only been taking them for 1 year so far, but I just thought I would tell you that so that other people will know that in case they want to take the trazodone tablets.
So I haven't been aware of that, but the way that we might use it in practice is for people who are feeling quite depressed or quite agitated, also to try and help people sleep.
Yeah,
I don't know if it's helped you.
Originally, but she's decided that they probably might cure memory issues.
How interesting. Well, trazodone is a good drug. It's quite a safe drug in terms of side effects as well. So I hope that hasn't happened to you.
Yeah, but do you know that lady?
I hadn't known that at all.
Giovanna. Well, she's at the Cambridge Hospital.
Okay.
And you had someone from the Cambridge Hospital for your last meeting.
Oh, I wasn't in the last meeting.
No, I wasn't here last
Okay.
night, but I did notice that that doctor that I see in Cambridge Hospital was here a month ago, that lady Giovanna Marucci, who was originally in Leicester, she has moved to Cambridge Hospital now.
That's very interesting.
She was here originally, and she's moved, but we know her well. But I thought we might pick that up at the discussion, at the question and answer.
All right, well, sorry to mention it.
No, that's great.
Yeah.
So, an overview: treatment to exclude physical causes such as the urinary tract infection that you saw in the patient that I was discussing, and then target individual symptoms. We do not use medication first. The treatment should be behavioural first, because actually that's been shown to have the most significant effect in terms of longevity. But we would use medication if needed. And then the risk-benefit is essentially what we're working out when it comes to using medication. So take-home messages: that people with PPA can show a profile of psychiatric illness, and it's something that we think is really important to be recognised because it needs to be treated. That the number of symptoms can increase and can definitely change as the illness progresses. That anybody can be valuable. Both people suffering from PPA and carers are valuable in being able to assess any change in the type of behaviour and personality, and whether or not you feel that there is a change that you're struggling with is really important to be able to report it. That there is treatment available, and that the treatment itself should involve all disciplines such as neurology, social care, psychiatry, and it should be community-based as well, because obviously you may need to have that intervention over a period of time and to get to know your community teams. So questions, I think. That was it. No problem.
So I think we've got some time for questions. I mean, Anna and I will be able to do a tag team, but because I know her time is limited, it might be quite useful if you have particular questions for her, if you direct them to her. And we will want to get on and let you have some lunch, but I will be around during lunchtime as well if people wanted to have a chat. Okay.
I'm the wife of someone who had PPA, and I'm also a psychologist in the NHS. I'm delighted to hear you give priority to behavioural and social treatments and speech therapy before medication. What you say sounds wonderful. if you could be under a older person's psychiatric team with an assigned CPN who got to know you, that's in an ideal world.
Yes.
Certainly my experience was a diagnosis back to your GP, nothing, until we found these support groups. How realistic is it for most people here to access that quality of
So I'm
psychiatric
really glad
services?
you asked, because I'll explain. The lady, and I particularly chose this patient on purpose, she came to us 6 years after a diagnosis. She was 6 years into illness, hadn't been diagnosed by her GP, and the reason that she was diagnosed is because she got a urinary tract infection, became quite paranoid, and because it was an acute change and they needed to manage it, you can't have someone who just stays in their house all day feeling quite paranoid, that was the reason that she came to our attention. And it was also the reason that she came to the attention of the neurologists and then was diagnosed with PPA. That is not a scenario we would want. So we now see this patient regularly, she's care coordinated. I would have preferred to have seen her when she was starting to show symptoms of depression, rather than when there was a psychotic breakdown and we had to deal with her in crisis. So my answer is, I think people aren't being referred to the service. Because actually, if you're referred and you have a psychiatric need, irrelevant of any other illness that you might have, you would get treatment within the community mental health team. I haven't seen anybody at my end. This is also, I have to appreciate, there's local variation, and I can only really talk about what our service does. But if someone has depression, anxiety within PPA, we would see them in exactly the same way as anybody else with any other comorbid illness. So it's difficult, and there is local variation. From my perspective, so Susan, who's not called Susan, is going to be with our service for as long as necessary, and at the moment she's still care coordinated. That's the only answer I can give. You're right, it's idealistic in terms of does everybody receive this service. My answer is, if they're referred to me and they have a psychiatric illness that requires treatment, yes, they receive this service. I don't see as many as I should because I don't think they're referred.
So how would you encourage that to happen?
What, the referral?
Yeah, how would you
Well, yeah, so the referral is, I imagine, things like this, forums for PPA, because the patient that I'm talking about went to her GP multiple times and wasn't diagnosed, and was diagnosed when she went into acute trust with a UTI. So there is something there about education, and education in primary care particularly, because that's where the mainstay of our referrals would come from. And it did come from primary care, but all of it too late and because it was all a bit too dramatic. So the answer is about education, and I'm talking about education in terms of educating medical professionals.
So, but in terms of us though, not being medical professionals.
Yeah,
We
GP.
get to the GP and just push the GP.
Absolutely.
Okay.
Absolutely. And when I was talking to her daughter, because we know the family, and she was saying, no, I kept going to the GP, but and she'd gone about 3 or 4 times while her mother's language is deteriorating. My answer would have been, you keep going until you get the referral you need to get. But it's not normal. And actually, it does happen. If you've got someone advocating you, the people I'm worried about, the people who don't have anyone advocating for them, that her daughter could advocate for her. The worry is the people that we don't see because actually they live alone or they live with a partner and their partner doesn't go to the GP. So it's a problem, absolutely. But as long as they're identified, they do and are referred, they are seen and treated in exactly the same way as somebody else who might have diagnosis of depression, anxiety, psychosis. Sorry, you go. Sorry, there was someone just behind you for a second. Yeah, no, that you.
Sorry. Yeah, it's very difficult because just depression and anxiety is very easy to conclude with so many things.
Yeah.
And on top of that, our patient, in our family, has got a language problem that his first language is Turkish.
Okay.
He acquired English within his country for 30 years. That's gone. What's left is Turkish. And it's just very difficult. And the point where it starts, it became what is the track PPA is when you have scans. You know.
And it is very difficult.
Could you summarise the question?
Yes, sorry, I was meant to do that. So the question was, what about someone whose first language might not be English, and that in itself is deteriorating, so that they don't have very much language, but any language they have might be in a different language. How do you communicate with that person in order to be able to get them the services they require? So I don't have a great answer other than I see people who have no language at all and who don't necessarily have PPA, they've got Alzheimer's dementia. You still obviously have to find a way to be able to try and understand what's going on and treat. And it is creative. A lot of the process is to try and creatively work it out, to get to know the person. And that's, I think, psychiatry more than others, and I say this with a bit of a proviso, but we tend to have more time with people. So we tend to get to know them over a longer period of time. And during that time, I might spend an hour for a first assessment, and that's not that common in the NHS. Sorry. But it is really difficult. But I see lots and lots of people who've got dementia who don't have English as a first language, or who don't have any language at all. You still try. So you would always have someone who knows the person there to be able to advocate and to be able to explain what might be going on. You're trying to understand a change in behaviours. You're trying to understand different biological patterns, sleep, appetite, all of the things that we might see. But over time, you can build up a picture. It's not a 10-minute appointment like in primary care, which can be very difficult, I appreciate.
Can younger people be referred to old age psychiatry?
Yes.
It seems that you have that expertise.
Do you mean in terms of younger onset dementia? Yeah, absolutely. No, absolutely. So our service in old age psychiatry, the remit of the service is I see people who've got psychiatric illness who are 65 and above, but anyone with any cognitive change of any age, I would see. Yeah.
Could you say a bit more about apathy and
Yeah.
how you try to deal with it?
Sure. So apathy is a tricky one, because how do you judge apathy? Often apathy can be a symptom of depression, as in apathy looks like anhedonia, meaning not enjoying things you used to previously enjoy. So you're kind of going, well, why don't you go and do that? And they don't want to do any of the things that they used to enjoy. It can look like people are socially withdrawing, so I don't want to have any contact with the outside world. It can look like people don't want to make choices anymore. It can look like depression. What we tend to do is something that is essentially activating behaviour. So we change, you have to do exercises with someone every day. So for example, whether they want to or not, they have to go for a 20-minute walk. And then you put these things into an activity diary. So that over time, that tends to or can improve apathy. A lot of the time, apathy is worse for the carer, for somebody who's caring, because they're worried about the fact that the person with PPA is not doing anything and they're not enjoying themselves, etc. Sometimes that does require a bit of a break, and things like day centres are really helpful for that. One, to give the carer a break. Two, because being together all the time isn't necessarily the healthiest thing, and actually it is good for someone to see other people in a day centre where they may have activities that are already scheduled for them. So those are the kind of things that we might do. I hope that answers it.
Nothing will answer it.
It's
no,
difficult.
I mean, it gives a clearer picture
Yeah.
of how you attack the situation.
Yeah.
So, because it's a word that, well, means a lot of
Yeah.
things.
Yeah,
and it
absolutely.
means different people to different carers as to, and what they try to do to activate.
Yeah. And it doesn't necessarily shift as much, but they have more time, they have more active time. Yeah, of course.
Just to say, it's one of the most difficult things, I think, and one of the least well understood, and one of the reasons that people break. And it's apathy it can be an absolute nightmare to try and manage and live with. So we're aware of it, but it remains very, very difficult, poorly understood construct.
Yeah. I'm sorry, I think this was first. Sorry.
Apathy could also be mistaken for the fact that someone appears to be empathetic, but actually they are aware of their inability to enjoy what they used to enjoy, or to perform tasks that they used to, and they know they can't do it anymore, so they might come across as being empathetic.
Absolutely, and I would say, sorry. So, my understanding was you were saying that apathy can be related to the fact that people have insight into not being able to do the things that they previously were able to do. And I would say that that is often under the umbrella of depression, that apathy can exist. It is a really difficult one, because you can equally get people who look like they've got the symptom of apathy but actually aren't depressed at all. So it is difficult.
Or they don't understand what they're supposed to be doing.
Yeah, they don't understand what they're trying, what someone's asking them to engage with. Yeah, absolutely. Sorry, I think I'm not good at this in order thing. Go on.
Yes, obviously I have a million things I can say, but I obviously haven't got the time to say it now. I just want to say that Susan, who had such a long time, not Susan, but Susan. I am Susan. It took me 8 years to be finally diagnosed by the UCL, because I told them all the time, all my progressive word problems. I could see my MRI showing damage to the left temporal. No, you're fine. And they just denied me, even though I could say it's PPA, and then I would say it's SVPPA for years. No, and they just ignored me. But the other thing I want to say is I know SVPPA is meant to relate to FTD very much, read those behavioural things, but I don't have it at all, and I've never had it in my life. Right from the tiny child, I was the genius with the high IQ, and I was never ever frightened, worried, upset, anything. I was just the wild and free, and I still am. There is no of that changed at all.
I agree that I think it's important to say all of this, as in when I'm looking at research, that we are, it's almost stereotypical, we're talking about patterns of behaviour. That doesn't mean that everybody who's got a diagnosis of SV is going to present in this way. Absolutely.
Individual, totally. But also, just one thing you were saying.
Even more difficult, you're talking about patterns of behaviour over a period of time in progressive illnesses. If you were drawing a graph, you'd have an axis of time. I don't know whether.
And I was going to talk a bit about that.
Into the rate of progression of these illnesses.
So just to say about, absolutely, a lot of the research conflates not just the different subtypes, but also how long people have come from diagnosis. And we think it changes as the disease continues. So you're absolutely right.
Yeah, if you say 50% of those who have a particular variant are apathetic, do you mean sooner or later?
Yeah.
So when along the axis of time?
So this is a question about the fact that it's an evolving situation, and we don't know where we are in the disease, which sort of speaks a bit to the staging issue that I mentioned at the beginning. We want to try and study this some more. It's a bit like when people were first learning about the planets, astronomers used to come up with all these very odd explanations why occasionally they'd look out with their telescopes and planets seem to be moving backward, and planets seem to be moving, and they came up with all these elaborate theories. And eventually, I think it was Kepler came along and just said, it's because of this. And there was one simple explanation, but you need to have the right model of the disease. And so a lot of this variability, complexity, I think, if we understood the diseases better, we'd be able to understand and predict it. But we're like the astronomers with before Kepler, we've got the wrong tools, we don't have very good models of the disease. So this is why, we need more research, and we do what we can for the moment, but it's not a very satisfactory situation for all sorts of reasons. And you know that better than we do. And the thing I wanted to mention about the SV, PPA, somatic dementia, as we've always known it, is that it's even probably more complicated, because there is depression, but there's also this sense in which people can lose the concept of themselves. So part of the problem with the disease, as you know, is that people lose conceptual knowledge, but that can extend to themselves. And so their own future, the concept of their future becomes a problem. And so they don't see a future necessarily. And so this is something that we're only now just beginning to learn about. And it's a very, very different sort of depression to the sort of depression that we would, or maybe psychiatrists would be more used to sort of dealing with.
Rosemary might be wanting to ask the same question, but the question I want to ask you is, we're dealing with crisis.
Yeah.
You put in at the bottom of one of your slides, speech and language therapy, and this is essentially presents as a speech or language problem, whether it's received or expressive at the beginning. My experience is that the people I know with this disease, and I know a number of them now from different groups, is that as soon as they're given adequate speech and language therapy to enable them to re-engage with society, they cease to be apathetic because they can actually engage.
Yeah.
Would you say that's your experience too? Because it's getting speech and language therapy for enough intensity and the right sort of it is very difficult to get, but yet it could stop them arriving at your table with a crisis.
So I absolutely agree that if there was anything that I think there's a dearth of in terms of how our service works, sure, I always get a bit jealous of Queen Square because they've got really good speech and language therapy, is our SALT, our speech and language therapy. It's, we do have community SALT. I agree with you. Just being part of building a communication book, I have seen, has improved how someone, one, they have to engage with something that is for them, that is about how they communicate, the kind of terms and themes they use, and being able to open up again a world of going out, being able to ask someone something, being able to express, being able to have a conversation with your husband, all of those things, I agree, make a massive difference. I think once someone has adapted to being able to start to use language again in a different way, they are much better. But the reality is that they still have an illness to deal with that makes them different from other people, and they have insight into that. So I still think, I absolutely agree. The first thing we did actually was sort out SALT and the communication book and all of that stuff, although she was quite unwell at the time and it got a bit better. But she was still quite anxious about going out, and anxiety is a big thing. Feeling quite low about how futuristically, particularly relationship with the husband, how that was going to go, and things like she has grandchildren, what's going to happen in the future. And so once, you're right, once the communication is sorted, I think there's an emerging picture you get left with that is why over time this requires assessment. It can't just be this snapshot, but I absolutely agree with you. And if I could change anything, it would be that we would have better speech and language therapy.
Hallelujah.
So that's a ringing endorsement for the importance of multidisciplinary care, and actually what we ideally need to manage PPA is a multidisciplinary team. We absolutely need to have speech and language therapy, and we also need psychiatry, and this is a thing that we do not very often have access to. It's a very, very rare, valuable commodity. I'm just conscious of the fact that time is moving on and we don't want people to miss lunch. I've got a couple of very brief housekeeping type things, but I wanted to say first of all thank you so much again to Anna, who's come in while she was on call and given us a talk, and will, I think, make the presentation available for circulation so that people that want to digest those slides in more detail. Thank you so much, Anna. So this is a question about communication books for children. But yeah. Okay. So that, but we actually do have an interest in that very topic, modifying what's around for kids, but taking it into something that would be suitable for adult patients. But there isn't anything that I would regard as particularly useful at the moment. But we are interested to try and develop one, so we should probably talk about it off.
I can give you some links.
We will try and make a better one. Yeah. And I just say, just in terms of where we're heading, so lunch is out in the other area, just in the next room. But before we go, a couple of things, and Chris will remind me if I forget to mention anything, but about the small group discussions, which are in the other area, around by where you came in, actually, different rooms there. We will put up on the screen, and I think maybe also around in the area what groups we've assigned you to. But if you've got particular issues with those groups, please do let Chris know, sort of earlier than possible, really. We've got, as I mentioned before, assigned facilitators who very kindly have agreed to kind of lead the discussions. We've got note takers. The thing I wanted to say about the note takers, and this is sort of like a winding up sort of comment really, is that they are all, I think, either fellows or PhD students who've come in who've elected to study PPA, and they've done that on the strength of the help that you've given and the cohort of people with PPA that we've assembled. And they are very bright young doctors, scientists. We're very lucky to have them, and they're very lucky to have you. And so this is really just a big thank you to all of you. When you see them there, being, you know, hopefully bright and nice and polite and all that, that they're here because of you. So I wanted to thank you on their behalves very much for that. Is there any housekeeping things that I forgot to mention, Chris? Because now's the time, probably.
So we will be moving chairs from this side of the room into the small areas. We don't have enough chairs because there's so many of you, which is great. But that means if you could keep your belongings on you, sort of over that, so we don't take anyone's possessions with us.
And there is one final thing before we break up. They think they've escaped, but they haven't. We've got, I left the best till last. We've got, they don't want me to say they're lawyers. They're members of the UCL legal team who are here to learn today. Rachel and Adam, they're at the back there they are. We're very excited because actually this is, as obviously people have already said today, and they're, I'm sure, beginning to learn, they didn't know before, a massive issue for people with rare dementias as to how they kind of interface with society and the law and the very many issues that it raises. And so I think they'd be delighted to chat to you a bit more about your experiences and sort of see how they can best help. But they're very welcome today, so they're another part of the initiative that we've started today. I think that's it. Thank you very much, and bye for now.